Next, we are going to have a video presentation because Dr. Tushar also has instruction course at the same time in a different hall right now. So I'll be playing this. Will audio be available? Yeah.
So very good morning and my gratitude to Nikunj for having me in his IC, and I'm sorry for not being there in person in the hall right now. I'll be talking about post-RK and post-LASIK cataracts and what is different about them. So the challenges that are involved in these cases include preoperative, intra-op, and post-operative challenges. So starting with the challenges that we encounter preoperatively. Well, the biggest challenges in preoperative evaluation in these cases is that of keratometry and IOL power calculation. Then there's also the dilemma of which intraocular lens to implant, whether we should go for a monofocal lens or a multifocal lens, and what should be the target refractive error in these patients. Now, the limitations that keratometers and placido topographers have in these eyes is that they are based only on the anterior corneal curvature. They don't really measure the posterior corneal radius, and they extrapolate that using an assumed ratio between the posterior and the anterior corneal radius. Also, they are blind to where the exact corneal center is, and they must extrapolate that information. This is where corneal tomography helps. And what I prefer to use is the Pentacam Holiday EKR map, which basically is designed to take into effect the refractive effect of the anterior as well as the posterior surface. And this calculates these values using the Snell's law, and the final K values that you get from this can be used directly into an IOL formula that is based on a refractive index of 1.3375. Now, this is what the holiday EKR maps look like. You have the AKR values in different zones centered at the pupil. You have various parameters against the mean zonal EKR. Then you have a histogram which shows the relative frequency of EKR. And then you have the EKR 65 mean and the EKR power map. So when you look at this cornea and try and analyze, you see the histogram has an extremely uniform appearance. There is a single peak, and the standard deviation also is extremely low. So this is quite a regular cornea. And if I get this cornea post LASIK and I have to do a cataract surgery on this patient, I would go for a multifocal lens. Now, this, on the other hand, is a much more irregular cornea. You can see that the histogram also is a little spread out. There is a peak, but there is a lot of variation, and the standard deviation is quite high as well. So in this particular patient, I would try to avoid a multifocal lens. I would want to go for a monofocal lens here, but I would be okay with going for a toric lens, because if you look at the K1 and K2 values in the different zones of the EKR map, you will see that they are quite uniform. So this patient, though, having an irregular cornea, would definitely benefit from a toric IOL. And I would counsel that, this is an irregular cornea, but I would definitely go for a toric IOL in this particular case. Now, in post-refractive cases, all you need to do is to feed these values into the ASCRS online calculator, which then gives you a measurement of the IOL power from different formulae, and you can take the average of that and use that for your calculations. Now, what should be the target refractive error for your patients? If it's a LASIK patient, I go for a plano target refractive error, because we are usually quite on point with these calculations, and you don't expect much of a refractive variation post-operatively in these patients. On the other hand, in patients who have undergone an RK, I try to target myopia, and the more the number of cuts, the higher I expect the post-operative hyperopic shift long-term to happen, which is why I would target a higher amount of myopia in somebody who's had more cuts. So with somebody with 12 or more cuts, I would target a -2 diopters of residual myopia. Now, in spite of all of these measures, and in spite of trying to get the best measurements and the best calculations, there are occasions where you really don't have answers. So, for example, this particular case was a 35-year-old woman who had undergone LASIK previously. Now she has a grade 2 cataract in both the eyes. So now, in this, with the optical biometer, I did not get any measurements. The axial length taken from the ultrasound shows that this is a high myope. And when you look at the pentacam, just see how flat this cornea is. So you have keratometry mean values of about 25, 26 diopters. And when you look at the EKR map, you can see that in some of the zones, the cornea is as flat as 21, 22, 23 diopters. So I went ahead and tried to calculate the IOL power using the ACRS calculator in this case, but the calculator refuses to calculate and tells us to check our values instead. Then what I realized is that the calculator doesn't accept any value lower than 35, 31 diopters. So there is really no way to calculate these IOL powers with any formula in this case. So I did a little bit of trial and error. I saw how the IOL power was changing as I went from a keratometry of 31 to 32 to 33, and then tried to extrapolate how it would vary should I go to a more flatter cornea. And based on my assumptions and my extrapolation, it of course was not a precise calculation. I went for an IOL power of 21 diopters. So here we did have a little bit of hyperopia, but the patient was reasonably satisfied. And then we had to go for the left eye, and I tried to aim for a lower residual refractive error. So I went for 23 diopters. In this case, there was about zero point 0.5 diopter sphere left. So all in all, reasonably good outcome, but always, difficult to predict this, and this could have gone wrong as well. Then the challenges that happen intraoperatively. So when you have post RKIs, the challenges that you face to begin with is where do you place your incision and whether you should go for a clear cornea or a sterile tunnel. So if it is an 8 incision RK, or even sometimes a 12 incision RK, you can go ahead and place your incision between two RK incisions if there is adequate space for that. But if there isn't, you have to plan a sterile tunnel. Also, you should keep your parameters reasonably low. You don't want the incisions to be opening up because that is something that can always happen. Also, to the extent possible, avoid chamber shallowing. Try and inflate the eye with viscoelastic as you withdraw your probe, etc. When it comes to post LASIK eyes, an important consideration is to take care of the flap. Make sure not to disturb it because you can have epithelial ingrowth, etc. later on if the flap is disturbed during the cataract surgery. The parameters, of course, would be as you would have for any myopic eye that you're operating. Now, this is a patient who is undergoing flax post RK. In the anterior segment OCT, you can appreciate how flat the cornea is. And this is another patient who has undergone flax, though the incisions were made manually. So we are trying to aim for the incision being between the RK incisions here. The same with the side port, having it between two RK incisions. And in spite of all of that, you can still have these leaky incisions, as in this case, where you just have to suture the RK incision that is opened up. So post-operatively, this case was fine, and otherwise this was uneventful. Post-operatively, the challenges that you encounter are related to the hyperopic shift that happens in post-RK. And that is why you would rather have some amount of myopia post-operatively, because there is going to be a hyperopic shift happening with the patient, and the patient should be informed of this. And that can cause a hyperopic shift soon after the anything of that sort. Let that edema settle down, and you might most likely will have the refractive error come down. Also, be aware and also let your patient be informed of the possibility of refractive surprise. No matter what measures you take, there can always be surprises in these cases, particularly post RK. So to summarize, IOL power calculation is probably the biggest challenge, and corneal tomography and the ACRS calculator play an important role in being able to hit the target with these calculations in post-refractive surgery eyes. The challenge intraoperatively for post-RKIs is where do you place the incisions and the possibility of leaky incisions, which does happen post-RK, in a cataract surgery post-RK. Now, refractive surprises are also quite possible, and the patient should be well aware of it, and if possible, try and get a special consent from the patient indicating that he has been informed of all of this. Thank you, and thank you so much for having me. Thank you.